everyone, and welcome to the first episode of the IGCS Education podcast on malignant bowel obstruction in gynecologic cancer. I'm Peter Grant, the co-chair of IGCS Palliative Care Education Workgroup and a gynecologic oncologist from Melbourne, Australia. This podcast series about malignant bowel obstruction at the end of life will shed light on one of the biggest challenges in gynecologic oncology. It's a 5-episode series and will feature global experts sharing their expertise on topics such as diagnosis, decision-making, ethical dilemmas, symptom management strategies, surgery interventions, emerging treatment, and the future of care. I'll be joined during each episode with my co-chair, Dr. Anisa Mburu, a gynecologic oncologist from Kenya. Nisi's been held up, but she'll join us during the podcast and will speak during this. Well, without further ado, I'd like to welcome our guest speaker, Dr. Stephanie Lheureux from Toronto. Thank you very much for joining us today. Would you briefly introduce yourself to our listeners?
Thank you so much for having me with you today. It's really a pleasure and an important topic that we discuss together. So I'm Dr. Stephanie Lheureux. I'm a medical oncologist working at Princess Margaret Cancer Centre in Toronto. And my practice is focusing on gynecological cancer, supporting women through the journey of gynecological cancer and the drug development program as well.
Thank you very much, Dr. Lheureux, and we're looking forward to hearing about your expertise and knowledge in this area. During today's episode, we'll be focusing on defining what malignant bowel obstruction is and how it differs from other obstructions, how to diagnose it in various settings, and relevant investigations with some particular reference to low and middle resource countries. I'll set a scenario that's commonly seen in any gynecologic oncology department. A woman in her mid-50s who's had multiple lines of treatment for ovarian cancer, is platinum resistant and has no further active agents available to treat the cancer. She presents with increased abdominal distension, colicky pain, some vomiting, just 5 weeks after her last cycle of chemotherapy to which she'd shown no response to the course. Dr. Lheureux, my first question is, in your experience, do we have an appropriate management paradigm for this presentation and condition? Or is malignant bowel obstruction due to recurrent treatment refractory ovarian cancer still an unresolved problem?
Thank you so much for this question. And unfortunately, it's a situation that we see quite often in our practice. Treated women with ovarian cancer, unfortunately, nearly half of the women diagnosed with ovarian cancer, with time and resistance to the treatment, the patient have a high risk of developing malignant bowel obstruction. Why? It's because the tropism of ovarian cancer is often developing the peritoneal disease. And given the peritoneal disease, there's a lot of impact in terms of the bowel. And unfortunately, with resistance to the treatment, there's disease progression and there's increase of the extension of the peritoneal disease that impact the bowel function. And unfortunately, we see this scenario of malignant bowel obstruction, which is a significant complication for our patient. I think it's important to have the podcast to really highlight this situation because unfortunately, I think there's still a lot of work that is needed in this area to help our patient because malignant bowel obstruction is seen as a very serious complication and end of life symptoms management. But I think there's a lot of work that is needed to actually help this woman because as you mentioned in your case presentation, this woman has a lot of symptoms. One of the symptoms that we often see is the nausea, the vomiting, the abdominal distension. We can also have some constipation, and sometimes we also see overflow diarrhea as well. So the symptoms can be very difficult in terms of the impact on the quality of life. And unfortunately, this patient, given the symptoms, often require initially some admission for acute management. So it's important to actually do the diagnosis of the malignant bowel obstruction and really try to see how we can help to manage the symptoms that our patient feel. So in terms of the, maybe we can go back at what is a definition of malignant bowel obstruction. So malignant bowel obstruction is initially defined by the clinical evidence of bowel obstruction based on the history. So having a history of ovarian cancer is a high risk factor for developing bowel obstruction. Definitely have a physical examination. As you mentioned in your case, you often see the abdominal distension with some GI symptoms. And then after, we often complete the diagnosis by some radiological examination. So in terms of pure definition, bowel obstruction is defined as a bowel obstruction beyond the ligament or treats and related to extra-abdominal cancer with incurable disease. So that is the definition of the malignant bowel obstruction. And then we need to characterize more this bowel obstruction, and you can characterize this malignant bowel obstruction based on the site, as you say. So either you can have a malignant bowel obstruction from the small bowel, and if you have a small bowel obstruction, it can be either proximal or distal. And if you have a bowel obstruction from the large bowel, it's another type of obstruction based on the site. And you can see that by imaging. You can also characterize the malignant bowel obstruction by the severity of the bowel obstruction. It can be either complete or partial, and that can sometimes impact the management as well. And often when we talk about the malignant bowel obstruction, is often a mechanical obstruction. It's a structural barrier, which is related specifically in ovarian cancer due to the parental deposit that actually impact the extramural bowel and unfortunately lead to the obstruction. It's also just wanted to highlight what is actually a parental deposit, because we talk a lot about that. So this parental deposit is actually tumor implant on the surface of the peritoneal, on the bowel and the omental fat. It can be seen as nodules, so we'll really see the nodule on the imaging, or sometimes some plaque, and it's called sometimes the thickening of the peritoneum, and is usually a site that we see in ovarian cancer. Another component of the malignant bowel obstruction is definitely mechanical due to this parental disease, but there is also potentially a functional impact of the malignant bowel obstruction, because when you have this parental disease, you also disturb the motility of the bowel. So you have, due to this tumor infiltration of the peritoneum, you definitely have a functional impact, and you have some motility disorder regarding to this parental disease. So that also contributes to the mechanical bowel obstruction. And you also have other factors that can impact the function of the bowel. And for example, hypokalemia or some pharmaceutical agents such as opioid can actually impact the function of the bowel, that actually participate to the bowel obstruction as well. So I think sometimes, depending on the site of the malignant bowel obstruction, symptoms can vary a little bit. So for example, if you have a really proximal small bowel obstruction, one of the main symptoms, the early onset of the symptom because of the location, would be really the nausea and vomiting. And that would be definitely worse with food intake. So if patients try to have some food intake or even drinking, then you will have the nausea and vomiting very quickly. And it's often usually associated with upper abdominal pain. If you have more distal small bowel obstruction, the main symptom will be diffuse and progressive abdominal pain. You can have late onset of vomiting and unfortunately possibly some fecal vomiting as well. You will have a moderate to marked abdominal distension, and sometimes as well patient will not have any bowel movement or pars flatus. If we look at the symptom from the large bowel obstruction, the proximal large bowel obstruction would be similar to the small bowel. if you look more at the distal large bowel obstruction, it will be more constipation, and the patient will have difficulty to have bowel movement. So sometimes it's important to remember that in the case of the partial bowel obstruction, sometimes the symptoms will be partial, and it's really important that if you have a suspicion of malignant bowel obstruction, to actually complete the investigation with some imaging. I just want also we talk a lot about the symptoms and the fact that the patient usually feel this distension, the nausea, vomiting, they don't pass gas, they don't have bowel movement. That is really the symptoms that are often related to the malignant bowel obstruction. But I just want to highlight that sometimes we see overflow diarrhea. So that can be sometimes confusing, but can be seen in fecal impaction. And you have the impaction of the feces above the level of obstruction, and sometimes you can have this overflow diarrhea as a symptoms as well. So just something to be aware of. So in terms of the clinical symptoms, I think we discussed that well. And if we have a suspicious of the malignant bowel obstruction, then we often complete by imaging. So in terms of imaging, sometimes we can start with an abdominal X-ray is often what we start with. And often in the X-ray, you will see multiple air fluid level. And that will be the diagnosis of the malignant bowel obstruction. The X-ray can also help us to potentially look at complication, because when you have this distension of the bowel, you can unfortunately have additional complication to it. Because with this distension of the bowel, you can unfortunately sometimes have hair under the diaphragm, which could be related to a perforation. And you can also sometimes see pneumomatosis intestinalis because of the gas within the bowel wall, and sometimes can be seen in a bowel ischemia. So the imaging as well can help us to do definitely the diagnosis with this multiple air level fluid, but also potentially some complication, because it's true, like the imaging of the malignant bowel obstruction, you will definitely see the distension of the bowel due to the accumulation of the content of the intestinal luminum, which from the accumulation of the different secretion that you have normally in the bowel. And unfortunately, this accumulation of secretion unfortunately damaged the intestinal epithelium and triggered the inflammatory response. So you can also see some intestinal edema, hyperemia, and production of inflammatory mediators. So even if it's in a way a problem of the bowel, you can have some systemic symptoms due to the reaction of the inflammatory that is related to the accumulation of the secretion of the bowel. So another complication that you can see as well clinically is bacteremia, because you can have bacterial overgrowth during this accumulation of the secretion of the bowel, and you can have translocation of the bacteria. So we just need to ensure that there's no complication in terms of sepsis as well. Yeah, go ahead, please.
Sorry. I was just going to ask about the imaging you use. A lot of people would say CT scan with contrast, but some centres may not have that availability, and would just a plain X-ray with hydrophilic contrast, gastrographin or something give you similar information, do you think?
Yeah, so it's a very good question. So the ideal is to have the CT is true, because the CT can give you the information about the site of the bowel obstruction between the small or the large. It can also provide you an information that sometimes can guide also the approach to treatment, if it's a single or multiple level. In the small, bowel obstruction is often multiple level. Sometimes in the large bowel obstruction, it could be single. And sometimes if it's a single site of bowel obstruction, we sometimes can offer some specific intervention with interventional radiology or sometimes palliative surgery. So that CT scan can give us this information and can also inform us about potential complication with perforation, bowel ischemia, fistula potentially, that you cannot really see well in the X-ray. But an alternative that sometimes we use actually in our institution is a tomogram, which is not a CT scan, which is the access is actually easier to have access to tomograms as CT scan. And it provides you a lot of information that help to guide the management.
Okay, sorry to have interrupted you. We are joined by Dr. Anisa Mburu now, who's got onto the meeting. But I'll let you continue with your investigations, and maybe Nisi will have some questions for a little later on.
Yeah, thank you so much. And thank you, Anisa, for joining us. It's a pleasure to have you as well. So in terms of the investigation, I think we discussed the importance of the clinical diagnosis and the clinical management, given all the symptoms that the patient experiencing. And the diagnosis is a combination of clinic and imaging. But we also often complete the investigation by doing blood work. The blood work is really to try to see the status of the patient. So often the blood work is kind of complete blood work. So I often do a CBC, specifically because this patient that we presented had chemo. And we know that sometimes you can have a neutropenia, thrombocytopenia with the chemotherapy. So we just, you often do a CBC. We do also a complete electrolyte assessment, sodium, potassium, chloride, bicarbonate, magnesium, calcium, phosphate, to actually see if there's any disturbance of electrolyte, which we often see with malignant bowel obstruction due to the change in the metabolism. We often do as well the albumin because often these patients have symptoms, few days and sometimes few weeks prior to the acute episode of the malignant bowel obstruction. So often when you see a patient with an acute malignant bowel obstruction, the day or the week before, they will have some change in the bowel, the oral intake was not as good, they felt full quickly. So the nutritional status is often something that we assess as part of the investigation. We often do as well the liver enzyme, and we look at the lactate as well, just to see if there is any acute component of the malignant bowel obstruction as a complication that we discussed earlier in terms of potentially sepsis or bowel perforation. So it's often what we do in terms of the investigation that will guide the management of the patient. And in terms of the management of the patient, going back to your initial question, it's something that we definitely need to work together as a group to try to unify and have some standardized approach to the management of this patient. We try to set up a kind of a standardized assessment for our patient here at Princess Margaret to guide the treatment for this patient, because often this patient go to different sites. Sometimes they go to the emergency locally, sometimes they go, so this patient can be managed by a very different people, not necessarily specialized in ovarian cancer. So we try to have some education and try to have some standardized document to help the management of this patient. And often the first thing that we suggest is that there is a suspicion of malignant bowel obstruction is really to keep the patient NPO, because we see the distension of the bowel, so we don't want to add anything. So one of the first management is to keep the patient NPO. And if the patient vomit a lot, we discussed to have the nasogastric tube to really help the symptoms of the patient, and then trying to support the patient with IV therapy. And that IV therapy is really based on the symptoms of the patient to really help them with the pain, because often these are abdominal pain. So often we have some pain management. Regarding the nausea, we give some antiemetics. And we were talking about the inflammation of the bowel due to this accumulation of the fluid. So we often offer steroids. The steroids is often for a period of days, but we often start the patient on steroids. We often suggest a proton pump inhibitor to help with the reflux that they have. And also what is important, because even if the bowel is a malignant bowel obstruction, the bowel still has a secretion, and we don't want to accumulate too much fluid. So we often order some anti-secretion agent for our patient. And another aspect of this management is really need to be multidisciplinary and interdisciplinary management, because these patients have a lot of symptoms, and it's really important to have a goal of care discussion, because unfortunately, as you mentioned, we often see this malignant bowel obstruction in the platinum resistant when the disease progress despite different lines of therapy. So it's really important to have a discussion with the goal of care, with the patient and the family support, and really have, if the patient was not seen before, having a palliative care consultation to really help managing the patient during this specific time.
Nisi is here now, and I'm going to throw her in the deep end and just see, have you got any questions that you'd like to put to Dr. Lheureux?
Absolutely. First of all, thank you so much for your patience, and thank you for doing this. And for me, I think it's just what you finished with. You said these patients need to be managed in a multidisciplinary way. Could you tell us who constitutes in your team and how you think this would differ in a low resource setting, and how maybe this can be, especially for low resource settings where they don't have a palliative care specialist, they might not have a surgical oncologist. How can these roles be shared, in your opinion?
No, thank you so much for the question. And I think it's this interdisciplinary, so it's why I add the interdisciplinary words in the approach, because in our institution, we were able to have a nurse-led program focusing on malignant bowel obstruction, given the need of our patient, and trying to actually, because as I said, most of the patients initially in the acute symptoms are admitted, but some of the patients may not require admission, and try after to be managed at home. And I think the nurse support is something that really changed how we manage our patient, because you can have a more proactive approach as well. So I think the nurse can play definitely a role in this setting. And in terms of, initial management, I think, as we say, initially they have the emergency visit. So it's important also to focus on the education of the healthcare professional about this specific complication of an ovarian cancer, but also, and I think it's important to have the education of the patient, because sometimes from patient perspective, they have ovarian cancer, and they sometimes are not aware about this potential complication related to the bowel. So I think to have a proactive approach with patient education, to say that if you can have some specific, and we developed actually a MBO framework in our institution to see that this component that we can use to identify potential patients at risk of malignant bowel obstruction, and trying to provide them with some specific education tool for them to be aware that they can try to initially help with their bowel management regime and try to support them, that when this episode come, I think they already know that it's something that can be seen in ovarian cancer, because sometimes still a surprise and they don't understand. So I think to have this education from the patient and the entire healthcare team, I think it's an important component. After, it's true, like, you know, when you have the diagnosis of the malignant bowel obstruction, it's true sometimes, depending on the characterization of the bowel obstruction, we can sometimes discuss with the intervention radiologist the surgery. But that could be sometimes difficult. And as we say, the most important thing in the context of malignant bowel obstruction is the symptoms management. So I think that it's where the palliative care play a role, but I think that role can be shared amongst a different interdisciplinary healthcare provider.
Thank you. That is a really interesting concept to perhaps finish this podcast on, about preemptive intervention, and which is a really interesting approach. We're just about out of time, though. Have you anything you'd like to add, Nisi, before we tie up this meeting?
Actually, not quite. I think it's been quite an educative podcast, and I love the way we've ended up with all this decision making and all the how you need to speak with the patient, the relatives, because that's actually what we're going to focus on in our next episode, where we're going to discuss decision making, the ethics behind management of malignant bowel obstruction, and communication of management options. So this has been pretty amazing. Thank you.
No, thank you so much. And you're completely right. I think it's important to discuss about the healthcare system, the patient, but also the caregiver, because there's a lot of question that is often raised by the caregiver, given the impact of the malignant bowel obstruction on the nutrition, on the hydration, and the symptom that the patient experiencing. So thank you so much for having me. It's been really a pleasure. And thank you for highlighting this topic and that are very important for our patient. Thank you.
Thank you. We will see you in the next episode.